I hope where you are, the weather is fantastic. My name is Kelly Cox, and I'm with the International Myeloma Foundation here in Los Angeles, California. At this time, we're coming live to you, and you will be experiencing the Regional Community Workshop. I'd like to welcome some people here that will be speaking, and I'll go into this later. Dr. Paner from Rush University and Dr. Rafat Abonour from Indiana University. I'd like to start out, too, with thanking our sponsors, Amgen, Bristol Myers, GSK, Janssen, Karyopharm, God, I never say that right, I'm so sorry, Oncopeptides, Takeda Oncology. As you follow up with our workshop, the speaker slides and video replay will be available after this. They'll come shortly within about 24 hours, and you can go back and look at this and take better notes. We do kind of go fast through this. On your screen, you'll see, a feedback survey. That is a clipboard. Please, please, please fill that out. You'll also see a question mark, and that's where you'll enter your questions. We'll try to answer them during the presentation. If not, we'll do it right after the presentation. So be patient. Today's agenda. You know me, I'm Kelly Cox. I'm the Senior Director of Community Workshops. I've been in this world for 20 years, and I've been doing workshops for 12, and I believe this is my 107th workshop. So we kind of got this down, and we really appreciate everyone who participates. The first talk will be Rafat Abonour, as I mentioned earlier. That will be at 10:05, and then at 10:35, we'll do questions and answers with the panel. 10:50, we'll do a little stretch break, which we'll all need. At 11 o'clock, we'll go into relapse therapy and clinical trials with Dr. Paner. 11:30, we have a question and answer panel, and 11:45 will be with Kathleen Colson. She's with the Nurse Leadership Board out of Dana-Farber Cancer Institute, Boston, Massachusetts. And then 12:05, we'll go at question and answer with the panel. So as you can see, we have a lot of good doctors here and great speakers and a great nurse that just specialize in myeloma. So you'll get the facts here, you'll get the right story here, and you'll understand what's going on. So put your seatbelts on, get a legal pad, a number 2 pencil, or however you do your notes, but get ready. And so here we go, Myeloma 101 and Frontline Therapy with Dr. Rafat Abonour. Thank you, doctors, for being here. Rafat, you're up.
Good morning, everybody. Thank you, Kelly, for doing this. I think you've been doing it for only a couple of years, you know?
Yeah, a couple of months, yeah.
Kelly has been great organizing all these support group and these talks, and I think they've been wonderful. I think, you know, they helped me too because I get to meet wonderful patients and hear their stories. So too bad we can't do it in person, but I hope next year we all vaccinated. We don't have Delta, Lambda, Kappa version of COVID, and we can just go back to normal life. So I'm going to try to be quick. I didn't know that I'm talking both of them in 30 minutes, so I will be skipping some slides. Don't worry about it. You have those slides. Kelly will provide them to you. So we're going to talk about myeloma 101. I'm going to describe this first patient. She was 39-year-old. She had back pain in 1840. And husband taking her from the fireplace to the bed, and she had more pain. They give her bitter infusion. She didn't do well, so she went to St. Thomas Hospital. They give her the typical hospital diet: wine, mutton chop, pint of quarter daily, because she looked like this. She looks quite emaciated with multiple pathologic fractures. The good news is that we don't see myeloma patient like this anymore. Right? When I started 26 years ago, I saw some patient look like that, but now I think people diagnosing myeloma early. What's nice about this case, because it was in 1844, the physician was quite astute. He said, well, you know, unfortunately she didn't make it. They did an autopsy on her. And they thought that, you know, these cells are, you know, oval shape, and they're probably inflammatory in nature, and, you know, talk about blood vessels action, you know, and all that stuff before we had all the technology to tell us how these ugly plasma cells behave. These are the plasma cells. They're supposed to make antibody to help us fight infection. One of them become malignant, and they start multiplying in the bone marrow. See, the bone marrow is full of these ugly plasma cells. So what happened is that, you know, we have kind of immune system that we all now talking about, because everybody in America wants to be vaccinated and have antibody. So the first thing is that you have these B cells that kind of, have a surveillance. They try to find what's the right, antigen to respond to, and then they become plasma cells, and these plasma cells accumulate in the bone marrow. And when you need them, they go, they make antibody to fight influenza or diphtheria and things like that. In the case of myeloma, unfortunately, you just have too many of ugly plasma cells, one type of cells. So that's why we call it monoclonal, proliferations of one kind, monoclonal. So you're going to hear that word a lot, monoclonal protein, monoclonal plasma cells. So what caused myeloma? We don't know. I mean, I think there are a lot of speculation. For example, benzene exposure, chemical exposure may cause that. It's very rare to see it in younger patients, but there's some suggestion that obesity, significant obesity, may contribute to the progression from pre-myeloma condition to myeloma. We're actually investigating that. So how do we test for myeloma? What are the major tests that are very important? Well, I told you these are, the cells in the bone marrow are unique, monoclonal. They produce one kind of protein called M-spike, monoclonal protein. The way you find it is by doing what we call serum protein electrophoresis or urine protein electrophoresis. You will find those abnormal proteins in the urine or in the blood, and you have to check the light chains. We'll talk about that in a minute, but you can do immunofixation. We need to do CBC because we want to find out if you're anemic or not. We need to do chemistry to find out if your kidney function is normal. Is your calcium high or not? And then we'll talk about the free light chain. It's a very important test. And then a lot of patients like to know their staging, and the way we know the staging is by checking a couple of things, beta-2 microglobulin and LDH. These are blood tests. And unfortunately, everybody will have their favorite test called bone marrow biopsy, and that's where you find the plasma cells, the myeloma cells, and you study them by chromosome analysis. And then you have to find the lesions that these cancer cells cause by either X-ray, CAT scan, MRI, PET scan. So this is the serum protein electrophoresis. On the left is the normal distribution. On the right, you can see there is a very thick, dark band on the right, give you this spike. That's the monoclonal protein. And by immunofixation, prove that. Now, there is a new kit on the block called mass spectrometry. So mass spectrometry is basically you take the serum and take all these protein and check their size and figure out what they are, because that's really very sensitive. Because if I find a monoclonal protein in the blood, in somebody who's getting treated, for example, it may be related to the treatment because we give them monoclonal antibody. So, for example, here you can see a patient who's getting daratumumab or Darzalex and have a little spike that is related to the Dara, but they have the myeloma spike still there. So you can not be able to see it on this gel here with this purple colors. This just show you the whole, both of them, the myeloma and the Dara protein. But here on the bottom, on the right bottom, you can see you can distinguish between Dara and monoclonal protein. I think mass spectrometry may replace serum protein electrophoresis in the very near future. So how do myeloma patients present? What are the major symptoms related to the myeloma? Obviously being older is one of the things. So most of the patients are really in their late 60s, early 70s, and a lot of patients are going to have the abnormal protein in the blood, and some patients may have the protein in the urine, and about 70% of the patient are anemic on presentation. About 60% of the patient will have bone disease, and about a quarter of the patient may have kidney failure or high calcium. These are, in the middle here is a skull, and you can see these, black dots in the skull. Those are the lytic lesions. So imagine having a driveway, and your driveway, there are weeds or grass growing in it, so you get holes in your driveway. That's how myeloma grows, in those holes in a driveway. But if they're growing in the skull, that doesn't cause a problem. But if it's growing in the bone, it's going to make it a long bone, is going to make it fragile. So you can see this arm here now broken because of that lesion expanding, destroying the bone. So that's one of the major problems in myeloma, is bone disease. Sometimes myeloma can be ugly, grows outside the bone marrow. For example, on the right here, behind the eye, there's a little tumor here on the left side. So that we call these plasmacytomas. So sometimes myeloma patients have these little tumors in different places in their body, sometimes in the arm, sometimes in the head. And then obviously it can destroy the spine and press on the cord. That's urgent things that patient need right away, evaluation, steroid, maybe radiation, maybe surgery, depends on the condition. The other thing that is really nice is the PET scan. What's the PET scan? You don't take your cat and scan it with you. It's basically you get something that will light up in the tumor. So it's a sugar that is radioactive. We inject it to the patient and then we scan them. And what you can see, all these black spots here, that's where the tumor is growing. The brain will be black because the brain loves sugar, so that's normal. You're going to see it in the heart, that's normal. You're going to see it in the kidneys, that's normal. But if you see it in the bones or in other places, that's not normal, and that's how we tell if there's a PET positive finding. It's very sensitive assay and a good way to sort of have a baseline and then follow the patient after treatment to make sure these lesions disappeared. So the x-rays may be obsolete and may be replaced by whole body CAT scan, PET scan, or MRI because they are more sensitive. We do genetic analysis because it can tell us what kind of myeloma we have. Is it high-risk myeloma? Is it myeloma that is going to be ugly, hard to treat? Or is it easy myeloma, standard risk myeloma? So somebody who lost part of chromosome 17, we call it high risk. So this patient needs special attention, need continuous therapy, continuous monitoring, because if you leave them alone or you don't pay good attention to them, they're going to relapse early. That's what the high risk for relapsing early. So we take care of that. The other, so this is what we call stratification of the patients. It's based on how many cytogenetic abnormality. And so you have two of the bad cytogenetic, like, for example, translocation 414. What does translocation 414 mean? Part of chromosome 4, jump on chromosome 14. That's bad. Or part of chromosome 14, jump on chromosome 16. That's bad. So if you have two of those, we call it double hit myeloma. So that's another myeloma that you have to pay attention to. You have to treat it carefully. Look, this is just what we call, Kaplan-Meier, graph for survival. And if you have standard risk myeloma, you're going to live much longer than patients who have high risk myeloma. So it's very important that we come up with better strategy, better treatment for high risk myeloma. So not everybody who has monoclonal protein has myeloma, because there are two conditions before myeloma. One is very common, called MUGUS. About 3% of people above the age of 50 will have this monoclonal gammopathy of undetermined significance. Doesn't mean anything to the patient. They're not hurting from it, just an abnormal protein. We follow it. Most patients will live their life and die from something else. Then some of them progress to smoldering myeloma. Smoldering myeloma can be also watched without any treatment, but sometimes the high risk, and I'll show you what that means in a second, need to be treated. So basically, those are two important pre-myeloma conditions. And you can see the MUGUS. It takes forever to develop myeloma, but the smoldering myeloma, in the first 5 years, you have quite a significant number of patients become symptomatic, but then they become less symptomatic over time. They don't develop multiple myeloma. And so I would say to my patient, the longer you smolder, the less likely you're going to develop multiple myeloma. So if you smolder for 10 years, very unlikely you're going to develop myeloma. So the first few years are very important. And and this is how we diagnose myeloma today. So everybody has to have one of these CRAB criteria or these defining sort of myeloma defining finding. So if somebody had a bone marrow biopsy and there are more than 60% clonal plasma cells, more than 60% myeloma cells in the marrow, this is a myeloma patient need to be treated. If the free light chain ratio of involve over uninvolve more than 100, we're going to call that myeloma. If there are a couple lesions on an MRI or CAT scan, we're going to call that myeloma. So staging, you know, you can have that and you can look at it later. It's in your hand, you know, so we have stage 1, 2, and 3. Stage 1 tend to have a very long survival, and stage 3 to have a shorter survival. This is the high-risk smoldering myeloma. High risk what? Again, for progressing quickly to full-blown myeloma. That means your chance of developing myeloma within 2 years is over 54%. What do you have to have? 2 of these 3 things. A myeloma protein more than 2 grams, more than 20% plasma cells in the bone marrow, or involve over and involve a free light chain above 20. 2 of these will make you high risk for progression. And those patients either get treated, or my favorite thing is to go on a clinical trial, because I don't think we know the best treatment for high-risk smoldering myeloma yet. We need to do a clinical trial. All right. So current therapy for myeloma, there's a lot. And there's a lot in Frontline, a lot of stuff we're doing in maintenance. I have not updated that yet. And for relapse, look at this. When I started doing this 20 years ago for relapse, I would probably have 1 or 2 drugs. Now we have many, many drugs. So I think testing is involved. We're having better, novel therapy to use. And I think we are working on treating myeloma early, because that may cure some patients early. And a depth of response, I haven't talked about it yet, but I think that's very important. That will improve the outcome. So I think, the most important thing is that myeloma patients are living longer, because we're using combination therapy that leading to minimal residual disease. So let's go on to the my other talk. Is it there or not? I don't see the other Frontline slide. Do you have those somewhere or no?
You talk to him?
I don't. That's the only slides that we don't.
Okay, the Frontline slides. Where are they?
That's fine. I can talk from top of my head. It's okay.
Okay, why don't you do that?
All right. So let's go to. Actually, this is better. We can talk through this. So in the old days, what we did is actually we just had chemotherapy and steroid. And everybody hates steroid because obviously they have a lot of side effects. You get, agitated, you have high blood sugar, you're not sleeping. In the old days, we used dexamethasone 40 milligrams for 4 days. And then we added chemotherapy to it, and then we added stem cell transplant. And then what happened, I think, is that we discovered the drug Revlimid, because Revlimid is cousin of thalidomide. That's the drug that really sort of made a breakthrough. And this drug, thalidomide, can cause neuropathy. Revlimid doesn't cause as much neuropathy. So what we start doing is we start doing trial with Revlimid and dexamethasone. And we initially in ECOG, in Eastern Cooperative Oncology Group trial, did comparing dexamethasone, the high dose, the 40 milligrams for 4 days on, 4 days off, 4 days on, 4 days off, to once a week dexamethasone. And what we found that if you use high-dose dexamethasone, you're going to lose a lot of patients. So what we did is actually stop doing high-dose dexamethasone, and we give now 40 milligram once a week, and people are tolerating that better, and we're seeing good results. Now, in the old days, because we didn't have too many options, we used to say, okay, let's do 2 drugs. But the thing about it is that think about myeloma as a family of nasty cells. It's not that you have one myeloma cells that became abnormal. These myeloma cells can learn bad behavior over time, and sometimes some of these cells may not just respond to Revlimid dexamethasone. So that's why we use combination therapy. So instead of using Revlimid dex or Velcade dex, we started using VRD, Velcade Revlimid dex, and that led to improvement in the outcome. If you compare RVD, for example, to Velcade dexamethasone or RD, you're going to show that the depth of response is better and the overall survival is better. So 3-drug regimen as an induction treatment is used for everybody, regardless of if you're going to go to transplant or you're not going to go to transplant. So, and then we said, okay, now we have a new kids on the block. Which kid? The monoclonal antibody like daratumumab. So the question was, why don't we add it up front? Why do we wait until the patient is relapsed and heavily pretreated? Why don't we do it early on? So we have the regimen called DRD, Dara Revlimid Dex, and that's in the transplant ineligible patients. These patients had a beautiful response. They had large number of them achieve minimal residual disease. So that means, what does that mean? You look in the bone marrow with very sensitive assays, sensitive tests, and you try to do it by flow or by genetic sequencing, and you analyze 1 million cells, and you don't find a single myeloma cells. We call that MRD negative. The number of patients who got Dara in their induction treatment, whether it was Revlimid or was Velcade, who achieved MRD negative was much higher. So people start getting excited about it. And more recently, people start, listen, why don't we add Dara to the 3-drug regimen? So Dara, Revlimid, Velcade, steroids, or Dara, carfilzomib, Kyprolis, Revlimid, dexamethasone, added to the induction treatment for transplant patients. And what trials have shown that by the time you're ready to go to transplant, you have gotten rid of a lot of myeloma. So when you go to transplant, the transplant is not going to be dealing with a lot of myeloma. It's going to be dealing with less myeloma burden. And what happened is that after transplant, you get a lot of patients who are achieving what we call MRD negative results. So I think what happened is that the field has moved from doing 2-drug induction treatment, upfront treatment, it's only 2 drugs, to using 3 drugs and some now using 4-drug regimens. And I think that's probably staying with us for, a while, because we're just very happy with the results, because it's just the way we get rid of myeloma is just incredible. So the Frontline, you can divide the patient to transplant eligible or transplant ineligible. I think the induction treatment, the first treatment, may not be too different between the 2 groups, because older patients who are not transplant candidate actually tolerating the VRD regimen just fine. So I think that's a very good news for the patients, is that we are making progress even for patients who in the past, we were hesitant to give them 3-drug regimen up front. We are able to find the right combinations for the patients. So what's the beauty about frontline therapy is that we have multiple regimen, and we can tailor the treatment for the patient's sort of medical conditions. Somebody who's diagnosed and on dialysis, we have the right treatment for them. Somebody diagnosed and has severe neuropathy, we have the right treatment for them. So we can tailor the treatment up front to get the right results. And the second thing about upfront therapy is that you really need to know that you are responding. So what happened is that sometimes, unfortunately, what happened is the oncologist will give you treatment and may not check the myeloma protein after the first cycle. Well, I don't think that's fair, because if you don't know what the myeloma is doing, you may not be getting the right treatment. So if I have a patient who was diagnosed with light chain myeloma, and the light chain is, lambda light chain is 6,000 milligram per liter, and then, I don't check it after one cycle, and after 2 cycles it's 12,000, then I wasted 2 months. So I want to know that at least my myeloma burden is dropping by 20% after the first month. So I know that I'm getting the right treatment. But I tell you, now with these combination therapy, the drop in the myeloma burden is just incredible. I mean, I just had a patient who came from Alabama to see her sister, to go to San Francisco, and she presented with, she was tired and not feeling good, and hemoglobin was 7, and her IgA was 7,700. So unfortunately, we had to do urgent bone marrow, diagnose her with myeloma, and we started on RVD regimen. And then I saw her yesterday for her, cycle 2 treatment, and her IgA dropped to 540, from 7,700 to 540. That's what you like to see. You like to see that your myeloma is responding to the treatment. So you follow the myeloma labs on a monthly basis, every cycle, to make sure that your myeloma is responding. Otherwise, you just, and sometimes after 2 cycles for induction, we will check, and if you have not gotten more than 50% reduction in your myeloma burden, we say, you're getting a sluggish response. Let's augment your treatment. Let's replace one of the drugs or add one more drugs, because it doesn't take a genius to say, if you go into transplant and you still have, 25% of your myeloma versus somebody who has 1% of their myeloma, who's going to do better? The one that has less disease at the time of transplant. So that's very important. Obviously, the most important thing also is quality of life. So myeloma patient, when they diagnose and symptomatic, they're not going to feel good. But with treatment and time away, they should start feeling better. If they're not feeling better, there's something wrong, either because we're not providing the best supportive care, or because the side effect of the treatment. So one of the things I always say to my patient, side effects are not badge of honors. When you have something bothering you, you're weak, you cannot walk, you have neuropathy, you're fatigued, let us know, because we have a way to manage that. So I think those are the most important thing about, frontline therapy, is that you have to get a good response, and you have to have a manageable side effect profile. Communicate that with your treating team, because they need to know about that. So we're not going to talk about maintenance now. I think it's important that continuation of therapy, especially if patients who are MRD positive, it's important. And you're going to hear from my colleague, Dr. Paner, later about relapsed disease. And I think we're almost there, so we can probably, do you want to open discussion, Kelly?
We have some questions to the right. Do you see the questions there from George, Rafat?
Yeah, George said, my spouse has carried multiple myeloma on her pancreas from 3 centimeter to 9 centimeter after 3 biopsy, and found 15 centimeter on pelvis. She wants to know she is cured after VRD and acupuncture and traditional maintenance, Velcade maintenance chemotherapy. This is a long story here. Is it cure under your algorithm on MRD and next generation sequencing analysis? Well, first of all, obviously, we love to say the word cure, but most of the time we really, hesitant to say the word cure, because there are patients who are relapsing, 2, 3, 5 years later. And most of the time we are happier to say the patient will cure when they have no evidence of recurrence, 10 years out of, their treatment. So when you have tumors in the pancreas or things like that, so what you want to do is to say the patient is in remission and stringent complete remission is that you don't find a monoclonal protein in the blood or the urine, your free light chain is normal, and your PET scan is negative. So you don't see any tumors, you don't see anything active. Then you say the patient is in complete remission, MRD negative. And then what you do is you follow the patients. Because what happened is that if you are 2 years still MRD negative, no evidence of active disease, your chances to be alive at 10 years in remission is quite high. So that's very encouraging. The 2-year mark, MRD negative, PET scan negative, is a very good point to predict the cure or the long-term disease-free survival. Okay.
Dr. Paner, would you like to take the question from Amira? Does DARA sub-Q have less incidences of neuropathy over IV?
Sure. So in general, we think of daratumumab as a treatment that does not cause neuropathy. Drugs that commonly are combined with daratumumab can. So, for example, Velcade. Velcade is well known, probably #1 drug to cause neuropathy. If Velcade is given sub-Q, it's less likely to cause neuropathy than given IV. Less commonly, we see neuropathy with Revlimid, but that too can cause some neuropathy. So anyone has different opinion? Dr. Abonour, Kathleen?
No, I agree with you.
I agree. I completely agree. So I'm not sure if the patient meant, because I don't see peripheral neuropathy with daratumumab, and I didn't know if they were trying to say, is it Velcade sub-Q versus, the IV. So I agree with you.
Yeah, so with daratumumab alone, you should be safe either way, whether it's sub-Q or IV should not affect neuropathy.
I mean, the only advantage of sub-Q is the transfusion-related reaction in the length of the treatment. So when we used to give DARA only IV, the first treatment used to take a day or two. Now you can do it over 30 minutes and the patient goes home in a couple hours. So that's really the advantage of sub-Q is the transfusion-related reaction that can happen during the infusion. So, yeah.
The first infusion, right.
Here's a quick question. Given the results of Mount Sinai study, why should a patient on DARA get the COVID vaccine? Anyone want to take that for a point?
No, let me tell you, I think it's a very good question, and we're doing the analysis, and we're going to publish the paper. So let me tell you, DARA is an anti-CD38 antibody. So what it does is get rid of the plasma cells, and it doesn't distinguish between myeloma cells and plasma cells. So if you get vaccinated and you are on DARA, you may not develop an immune response. So, but what we found is actually the amount of DARA you're getting matter, and the timing of the DARA matter. So if I get a vaccine today and get the DARA next week or in 2 weeks, I may not develop an immune response. But if I get the vaccine today and I get the DARA 4-6 weeks later, I will still have the antibody. And as long as I'm not getting it more than once a month, you will still have antibody against the S protein, the spike protein of the COVID. So obviously, everything we do in medicine is risk and benefit. So if somebody gets newly diagnosed or newly relapsed with multiple myeloma and monoclonal antibody to CD38, either drugs that are approved now by the FDA, are the right treatment for them, you have to give it to them. But you have to counsel the patient is that when you start going to less frequent scheduling, you need to be re-immunized against COVID-19. In the interim, obviously, use the social distancing and things like that. But it's not a completely black and white, but I think you should know that DARA is a very good anti-CD38 antibody, and it can deplete these cells, and you can lose the response if you're getting a lot of it.
30 seconds here. Dr. Paner, do you have anything to add to that?
Yeah, so I would say It's still worth getting vaccinated, even if you are on daratumumab, for whatever benefit you can get from it. These vaccines are extremely effective, 95% in patients with intact immune system. Flu vaccine is nowhere nearly as effective, or pneumonia vaccine, and we still give them, right? Because whatever benefit we can get, we want to get that. I also want to make a comment that immune response consists of more than just antibody production. And what we can't measure in the lab is how the lymphocytes respond. And lymphocytes might be even more important than antibodies in immunity against viruses such as COVID. So antibodies, in other words, don't tell all the story how good or bad is your immune response. And knowing how safe these vaccines are so far, I would recommend patients, even on daratumumab, getting a vaccine.
Well, that's very good information. I wanted to thank everyone. Go ahead, Rafat. Go ahead.
No, I think I want everybody to be vaccinated, and I support that, and I agree with Dr. Paner about her, but I think it's probably need to figure out the timing of the data after the vaccination, because it may influence, the humoral response. But your lymphocytes are very important too.
Excellent. Kathleen, do you have any, or Kathy, do you have anything you'd like to add to it?
Nope, I agree with the doctors. Everybody should get vaccinated. It's very important.
Okay, great. All right, I want to thank everyone so far this morning. And Dr. Rafat Abonour, I'm sorry that we didn't have your proper slides up. That won't happen again with you, of course. All right, let's take a little break. I want to thank you for staying with us as long as you have. We had a lot of questions come up during the break. We'll answer those questions at the break after Dr. Paner. She's going to be talking about how to manage multiple myeloma symptoms and side effects. Oh, that's Kathleen who's doing that. Agnes is doing relapse therapy and clinical trials. Sorry, I read that backwards. Dr. Paner, go ahead since I said it wrong. Relapse therapy and clinical trials.
All right. Well, thank you, Kelly, again for having me present in the meeting. There's a reason why these two topics are closely related: treatment of relapsed multiple myeloma and clinical trials. And that's because majority of new therapies get approved during clinical trials in relapsed refractory disease. So today we will be covering, first of all, why do we do clinical trials? What are the ABCs? There is certain language and terminology that I would like to introduce to you to be better equipped to understand the literature and announcements that you read on new therapies in multiple myeloma. And then we will focus on updates in treatment of relapsed multiple myeloma. Treatment of relapsed myeloma is a very broad topic, because nowadays we do have so many therapies and people can stay on treatment for years and years. It's not uncommon to see patients on the 4th or 5th or even 6th line of the therapy. So I will narrow down and focus what I think will be of the greatest interest to you, since that's where I get most of the questions from my patients, and that will be comparing different anti-BCMA therapies that are upcoming and are going to change the landscape and natural history of multiple myeloma. It's a next big wave of therapies in multiple myeloma. So why do we do clinical trials? And that's because patients ask us questions that we can then turn into research questions to answer through clinical trials. Patients may ask, how did I get multiple myeloma? And really, they're asking us a research question, what are the causes of multiple myeloma, which is still not very well understood matter. Patients ask us, what is my stage? And I think what they really mean by that is, how can you predict what is my prognosis? How am I going to do with this? So what are the prognostic factors of multiple myeloma? That's active area of research. And will I pass it to my children? Are there genetic predisposition to multiple myeloma? We know it runs in some families, but most of the time it's a random occurrence. What can I do about my cancer? So which treatment option is the best? And should I participate in a clinical trial? That's the question that empowers to answer the question, can we improve currently available treatment options and current standard of care and explore new treatments to change the natural history of multiple myeloma? So really, we do clinical trials because of you. And this slide nicely shows how much research and clinical trials have changed the history of myeloma. We have different therapies lined up based on the year of FDA approval of these therapies. And in the bottom, you see columns that show how overall survival is improving each time something new gets approved for treatment of multiple myeloma. I don't yet have an update on overall survival in 2015. And the slide, that's a very important year in multiple myeloma history, because that's when first monoclonal antibody for treatment of multiple myeloma got approved. And since then, we've had various combinations of that monoclonal antibody with other standard of care therapies. We also now have therapies like selinexor, melflufen, belantamab. I did cover melflufen and selinexor in previous meeting. So this time I thought I'd focus on the newest approved therapy, and that's CAR T-cell called ide-cel. And just to compare and contrast, I will also talk about belantamab and bispecific T-cell engagers. So how does treatment for multiple myeloma gets into clinical practice? You know, we need to understand that drug development really takes years from the lab for treatment to get into a clinic. In a very first step, research is done in the lab on the cancer cells, not with humans, not even with animals. That's where we get an idea if the new therapy is able to kill cancer cells. And only then they get introduced into animal models, where we learn about potential side effects and also get an idea about the dose that we could introduce to humans. So we, especially with chemotherapy agents, with cancer therapies, many times the dose where a drug is effective and where drug can be toxic is very close next to each other. So it does take a lot of balancing and experimenting and testing to find that perfect dose. And that's usually what happens in phase 1 trial. That's when, after being proven effective and relatively safe in animal models, it gets introduced to humans. So first in human trials are phase 1 trials. They're usually small. They usually start with a very, very small dose and keep building it up based on how people are tolerating. So they answer the question, how safe is this drug? And what is the maximum tolerated dose? Or in other words, a dose recommended for phase 2 trial. In a phase 2 trials, we already have more patients participating, usually around 100 patients on average. And many new therapies for relapse refractory multiple myeloma will be approved based on phase 2 trials. And that's going to be the trials I'll be mentioning later in my presentation. Now, phase 3 are already very large trials. We have experimental therapy comparing treatment to standard of care therapy, if there is a standard of care therapy, or that could be a placebo if there is no standard of care. And that's where, drugs get approved in earlier lines of therapy, like in a first relapse or even a upfront treatment of multiple myeloma. To change standard of care for those early lines of therapy requires much bigger clinical trials to prove that they are better than standard of care. Natural history of multiple myeloma, unfortunately, does involve potential relapses. We still think of this disease as relapsing, and instead of word cure, we more comfortable using word long-term remission. We have all in our practices patients who have been 10 years in remission, 15, 20, and sometimes even in those patients we can still see a relapse. So the natural history from newly diagnosed, that's where Dr. Abonour talked. They get upfront treatment, perhaps a transplant, then they go on to maintenance therapy. And in that maintenance and remission phase can really vary depending on the biology of the disease, on patient's ability to tolerate therapies. It can be anywhere from a couple years to decades. When patients relapse first time, we call it early relapse. And when patients have had multiple relapses, we start to label disease as relapse and refractory. So clinical trial or drug development goes in a backward direction. You know, drugs start out with phase 1, phase 2 trials in relapse refractory disease, and then they are slowly introduced into earlier lines till they get all the way to the upfront therapy. I think one of the examples perhaps would be daratumumab, Dr. Abonour mentioned. That's the newest kit that's making into upfront therapy. And just in 2015, it was first time that it was approved for relapse refractory disease. So it does take years to move into earlier lines of therapy. So we talked about what is the phase of trial. That's important to pay attention when you read about new drugs. Are they early in development? Are they late in development? Patient population, you know, if you're reading clinical trials now, let's say about CAR T cells, they are being studied in patients with relapse refractory disease with multiple lines of therapy. So that information will not apply to the patient in the first relapse. You know, if you are relapsing first time, you may be only candidate for CAR T cells on a clinical trial, but not based on FDA-approved indication, because studies that led to FDA approval so far only are in early phase 2 relapse refractory disease. Randomized, that means that when clinical trials conducted, computer randomly divided people into two groups, one that received experimental therapy and one that received standard of care. It's usually neither doctor nor patient can influence which arm patient goes into. That's the only way to do a fair comparison. So overall response rates, how many patients at least achieve at least 50% reduction in tumor volume, which in multiple myeloma most of the time means reduction in monoclonal protein by 50%. Patients who achieve less, maybe 20% reduction, may be called as minimal response. And patients who have stable disease are those who have either less than 25% reduction or less than 25% increase. So their numbers are relatively stable, in other words. So for your reference, I will say in phase 2 trials, if the drug has 20% effectiveness rate, meaning at least 20%, 1 out of 5 patients had a 50% reduction in a tumor volume on the treatment, it's considered a very promising drug. Progression-free survival means from the day that patient started treatment, how long they stayed in remission. And that includes both patients who responded to treatment as well as patients who did not. So very closely related is terminology duration of response. That includes only patients who responded, how long they stayed in remission. So in other words, when you're learning about a drug, you want to know not only how high were the response rates, but also how long those responses lasted. So either duration of response or progression-free survival. And then overall survival is considered a gold standard in oncology. If you can prove that therapy helps people live longer, not only stay in remission longer, that is a worthwhile treatment. There's no better indicator that this is a good therapy. Adverse events, as long as you could be focusing on effectiveness on the drug, but you should never forget the side effect profile. Because if you can't tolerate the drug, it doesn't matter how effective it is. You're just not going to be able to stay on it and benefit from it. So this table shows us what are the major classes of the drugs so far approved for multiple myeloma. And I will focus on a column called anti-BCMA therapies, and that includes actually 3 different modalities of treatment: belantamab, which is monoclonal antibody drug conjugate; CAR T cells, which stands for chimeric antigen receptor engineered T cells; and BiTEs, which is bispecific T cell engagers. So BCMA is a novel target in multiple myeloma. It's something that plasma cells, myeloma cells express, but other cells mostly do not. And therefore, treatments that target that BCMA receptor, they can be very highly selective to kill plasma cells. BCMA stands for B-cell maturation antigen, in case you're interested. And we have at least 3 different modalities. They target the same receptor, but they act very differently. Their mechanism of action is very different. So you see antibody drug conjugate, for example, belantamab. That was the very first anti-BCMA therapy approved a year ago. Just a few months ago, we had another anti-BCMA therapy, a CAR T cell called the ide-cel, approved by FDA. And then bispecific antibody T cell engagers are still in a clinical trials in development. Now, this slide can be rather intimidating, but I wanted to show you how complex is the development of the drugs. And I really want to inspire some hope here with this slide. You can see that even though we have 3 different modalities to target BCMA, there are still a multitude of different drugs within each category that are being studied. It's a really good one, right? But this is how you get to that good one, through competition and innovation. All these drugs in development, they are meant to become more effective and less toxic. And there are many ways to do that. So that's where industry, pharmaceutical companies, and academia work really hard to figure out how to make things better. Now let's focus now on monoclonal antibody, on belantamab. Sorry, that's an antibody drug conjugate. This picture should help you understand how it works. So on the left side, you see a picture of antibody drug conjugate. Antibodies are always pictured as these little forks, and then the yellow dots is the drug attached to it. So when this antibody can recognize cancer cell receptor on the surface, it can also enter the cancer cells. It's like a key that opens the door into the cancer cell. And once it is inside, it can be broken down and release the drug that does the job. So it's a very neat mechanism of action because it really helps to tunnel drugs into the cancer cells and hopefully that way cause less toxicity to other healthy tissues. And not only can drug kill a cell, but antibody itself, the antibody portion of the antibody drug conjugate, can many times stimulate immune cells to recognize and kill those cancer cells. So things I'd like you to know and remember about belantamab. This was FDA approved based on phase 2 clinical trial for patients who were refractory to at least 3 prior lines of therapy. These patients were supposed to have had already treatment with IMiDs like Revlimid or pomalidomide, with proteasome inhibitors such as Velcade or carfilzomib, and also to be either intolerant or not responding to daratumumab, which is anti-CD38 monoclonal antibody. So in this phase 2 trial, overall response rate was 30%. So it's quite above that 20% cutoff where we say this therapy must be promising. So 1 out of 3 of patients will respond to this treatment. And what's unique about this drug, that patients who do respond tend to have rather long-lasting remissions, which in this group of patients is about a year. So progression-free survival was short, but it's the duration of response among those patients who do respond is the one that lasts about a year. It's also important to know that belantamab has a unique side effect. It can cause eye side effects, mainly dry eyes blurry vision. If you've ever had the feeling where you wake up in the morning with dry eyes and it's hard to open them, it's even hard to see, that's the feeling you can get on this drug. And patients have to use a lot of eye drops to keep their eyes moisturized. The reason it happens is because the drug conjugated to the antibody can affect corneal cells, the lining of the cell. And sometimes those changes can happen without symptoms. So that's why it's very important to see eye doctor every 3 weeks on this treatment. And if those changes are severe enough, the treatment has to be held. And that's quite all right, because majority of patients who are on hold on therapy till their eyes recover, they continue to respond to treatment. So most patients will recover, eyes clear up their vision, and going to be able to receive therapy again with belantamab. So if I would highlight strengths and weaknesses of this therapy, I would say it has advantage of being easily accessible. Antibody drug conjugates pretty much can be given in any oncology practice, in any infusion center that administers chemotherapy. It has relatively convenient schedule. It's given intravenously over 30 minutes every 3 weeks. And it actually is very well tolerated. Other than dry eyes and impaired vision associated with it, they have very little of other side effects. Blood counts could be low, but patients usually don't feel that their blood counts are low. We, on the other hand, don't see much of nausea or neuropathy. Those are the things that affect quality of life. So well-tolerated, easily accessible therapy. The weakness is that this is an ongoing therapy. Once you get started, you stay on it as long as it's working and as long as you are tolerating the treatment. The side effect of dry eyes can be fairly bothersome, and that's I would consider as weakness of this therapy. And also the fact that you now need to see 2 doctors to get your treatment, not only your oncologist, but also your eye doctor. Now let's have a look at bispecific T-cell engagers. So these are therapies where you have 2 antibodies connected, and one end of antibody can recognize cancer cell and grab it, and another antibody can recognize your immune cell, T cell. Those are the main immune cells that fight against cancer. So that other piece of antibody can recognize it, bring them together, and make the T cell kill cancer cells. See, many times cancer patients have enough of T cells, but they're just not doing the work they're supposed to. That's a problem with impairment of immune system in cancer patients, and why cancer cells can escape immune system and start proliferating. So bispecific T-cell engagers are also targeting B-cell maturation antigen on a plasma cell. They are currently available only in clinical trials. Of all the 3 different anti-BCMA treatment modalities, they by far are earliest in the development. These drugs also are administered as continuous therapy as long as you're tolerating, responding to treatment. There are quite few in development. Some are given as intravenous, some are given as subcutaneous injection, some weekly or every 3 weeks. So schedules vary. And response rates have so far been reported very high in early phase trials, so 60 to 70%. And what you need to know about side effects, it can cause something called cytokine release syndrome, especially with the first couple cycles. Cytokine release syndrome is like inflammatory reaction, as if you have flu. You could have fever, you could have weakness, fatigue, and that's a treatable condition, but it will require very close observation and contact with the center where you're getting your treatment. It can also cause neurotoxicity, and this time it's not only peripheral neuropathy, it's also central nervous system. So patients can develop mental status changes, seizures, So it's not common, but it is a fairly serious side effect to be aware of. And it's also reversible, just like cytokine release syndrome. So what I would consider as strengths of this therapy, very high response rates. Unfortunately, too early to say if how long the remissions will last, too early in development. And schedules for treatment can be relatively convenient, especially if you're getting therapy every 3 weeks. But even weekly dosing is something that patients with multiple myeloma are usually pretty experienced in getting. Again, it's only available through clinical trials. So if you are interested in getting this therapy, you need to look for clinical trials in your area. Weaknesses would be the side effects of cytokine release syndrome, neurotoxicity, and the fact that it's ongoing therapy. Now that takes us now to CAR T cells, the chimeric antigen T cell receptor T cells. These are really getting a lot of press attention, and most of my patients with myeloma ask questions about it. They are already now FDA approved, specifically ide-cel, but there are many, many more in development because we all think we can do better than the current CAR T cell. There's room for improvement. Let's talk about how these CAR T cells work. It's a fairly complicated process. So once you are assigned to get this treatment, a patient has to come in and get their blood collected. T cells will be extracted from their blood. It's a process similar to dialysis or pheresis. If you had a bone marrow transplant, you know what it's like. So those T cells are then sent to manufacturing facility, to the lab, where genes will be inserted into the T cells. And those genes will be expressing receptors that can detect your specific cancer cell because of this BCMA expression. So that's what we refer to as chimeric antigen receptor T cells. It's your own T cells, but now they have new function and new quality to recognize cancer cells. These T cells usually need to be grown and expanded because the more you infuse, the more likely they are going to work, though it has to, again, be balanced with side effects. So it can take up to a month for this whole process of engineering T cell. But when it comes back to the patient, it is infused, which looks a lot like a blood transfusion. Then T cells find the cancer cells and start killing them. And patients during this process have to be in a hospital because the reaction can be so strong and so quick that they can develop, again, cytokine release syndrome, with neurotoxicity, even tumor lysis syndrome. So things you need to know about recently approved ide-cel, the very first CAR T cell for relapsed refractory multiple myeloma. It's a one-time administration treatment. It's a little bit more like transplant than the other therapies I talked about. You get your infusion and you're done. Then you wait and see how well you will respond and how long you will remain in remission. You don't have to keep coming to get more therapy when you receive CAR T cells. It can only be administered in the centers that are approved for CAR T cell therapy. So many times it's the same centers that do autologous stem cell transplant. But that also means you may have to travel far away from home to get the therapy. After collection of T cells, since it takes about a month to manufacture them, patients may still need some bridging therapy to control the disease. And that is one of the drawbacks for patients with rapidly progressive disease, that sometimes they progress while waiting for those T cells to come back. Now, response rates with ide-cel in the phase 2 trial that led to FDA approval was 73%. And a quarter of those patients had very deep responses, MRD negative responses. So this was really unprecedented in multiple myeloma relapse disease, this degree of response rates. Progression-free survival has been reported 8.8 months, It's much longer for patients who achieve deep remissions. The deeper your remission response, the longer it's going to last. Cytokine release syndrome was common in 84% of patients, but in most of them, it was considered mild. It was manageable with steroids and certain other supportive care measures. And neurotoxicity was seen in 18% of patients. So what would I consider a strength of this therapy? I think a lot of us like one and done idea, that you get your treatment and then you just come in for follow-up. You don't need any additional therapy. And certainly the very high impressive response rate. So most patients with relapsed disease, if they can be candidates for CAR T cells, they should consider this therapy because by far it is the most effective therapy for relapsed disease. It does require hospitalization, and logistics can be complicated, including travel to specialized center, delays due to manufacturing shortage. Unfortunately, even though it is FDA approved, not all patients are able to get it because they can't make enough of CAR T cells fast enough. Hopefully, it's a matter of time and will fix itself, but for the time being, it can be a problem. And in that case, I would encourage to participate in clinical trials with CAR T cells because there are a lot more coming that could be even more effective than currently approved FDA. You should not get discouraged if you can't get it through your insurance. Now, when it comes to side effects, again, similar to bites, it's cytokine release syndrome and neurotoxicity, and all of those are reversible, but they can be tough to get through. So speaking of upcoming therapies, I think the next in line, most likely to get FDA approval, is cilta-cel. That's something you should keep your ear out. We hope this will happen in perhaps the next few months. It's another CAR T cell, but what's different from cilta-cel, from ide-cel, now it has two BCMA targeting antibodies. Not only one, but two different antibodies targeting the same receptor. And they are much more effective. Response rate was 97%, so practically everybody responds to this treatment. And what's interesting that majority of these patients had very deep responses, at least very good partial remission or a response or complete response was seen in close to 90% of patients. And among those who could get MRD testing done, 91% were MRD negative. So this is really groundbreaking, mind-breaking. This is extremely effective therapy. Now, duration of response, once patients do go into remission, it's close to 2 years, 21 months. And progression-free survival, since most of patients respond, is also about 22, 23 months. Cytokine release syndrome was common, 94%, but mostly grade 1 or 2, which we consider mild. And neurotoxicity was seen in 20% of patients. So with that, I'd like to give you some more hope. There is a whole lot more coming. There are new targets other than BCMA that's being explored. There are now bispecific T-cell engagers looking at different targets than BCMA. These new therapies are now being combined with FDA-approved therapies as well as experimental therapies. We are actually opening DREAM5 trial at Rush University Medical Center. That's a clinical trial that will combine belantamab with novel therapies that are not yet FDA approved. So we're very excited about this clinical trial. And we will see CAR T cells move into earlier lines of therapy. So again, if you're in your first or second relapse, you may not be candidates for CAR T cells based on insurance approval, but you should watch out for clinical trials in earlier lines of therapy. And with that, I'll be happy to take some questions.
Gosh, Dr. Paner, that was a lot of information. Thanks. I've learned some more things about CAR T and other things that I need to know about, so thank you. What I want to do here is go straight on to Kathy and then Kathleen, and then we'll answer some questions. I want to make mention, George, I see your questions. Jim, I see your questions, and Carolyn, I see your questions, and we'll go to those at the end of the presentation. So Kathleen, are you available to start up right now?
Thank you. All right. Thank you, Kelly. Thank you, Dr. Paner and Dr. Abonour, for excellent presentations. And, you know, as a clinical research nurse at the Dana-Farber, I've been a clinical research nurse there for over 21 years. And so, you know, I'm very proud and honored to have worked with many of these drugs that have been approved in the treatment for multiple myeloma back since 1999. So, as we know, it's just amazing in the treatments that we have to offer patients with myeloma. But, you know, patients, you know, are living longer with myeloma, and so they have a journey ahead of them in their treatment. And so when we talk about the journey, you know, you are part, as a myeloma patient, you are part of a multidisciplinary team. You know, you have your general hematologist that would refer you to a myeloma specialist, and that is the doctor who would determine what your treatment plan would be. But also, very importantly, you know, there are subspecialists that we refer to patients. So, for example, if a patient, say, has a vertebral compression fracture, we'd refer them to a surgical oncologist. Oftentimes, the disease of myeloma, because it does wreak havoc with our skeletal system, patients would need hip replacements, and again, that would be a surgical oncologist or a radiation oncologist. If a patient has a plasmacytoma or needs a fracture that needs to be spot well to get a patient out of, you know, any type of pain. You know, obviously you have your oncology nurses are the ones who administer your treatments in the clinic and are very well versed in all the treatments that patients are getting. And then we have social workers and dietitians. We have obviously emotional support for patients with offering, you know, social works or psychologists or you know, psychiatrists, and we have pain specialists for patients who maybe have lots of bone disease. And so we have this big multidisciplinary, you know, team that is part of your journey. So, you know, you can ask your myeloma specialist, again, very importantly, to refer you to any of these subspecialties. But very importantly is the primary care physician. And so I always tell our patients who have myeloma that we're there to take care of their myeloma, and they still need to have a primary care physician. They need to still have their annual physicals. They need to make sure that their primary care is setting up, you know, their colonoscopies when needed, mammograms, doing PSA tests for men. And so it's very important to be connected. If a patient is at home and they feel like they're getting a cold or upper respiratory infection, that they can go and see their primary care physician. So it's very important that, you know, we are as a team, always the myeloma specialist, the primary care, the subspecialties are all, you know, connected and, you know, are in contact with each other. But just remember, you know, if you have myeloma, it's always important to have your primary care physician involved at all times and seeing them yearly. So obviously we want to have the patient empowered, and it's important to participate in decision makings. You know, Dr. Abonour was saying, you know, we don't want patients that, you know, to, you know, wear a badge of honor and not ask questions and be a part of it. And it's really important to be part of the decision making team. They're in your therapy. So it's, you know, being knowledgeable, you know, you need time to consider what options, you know, patients, you know, there are young patients that are getting myeloma that have families. These patients need to work, and that maybe they would prefer, for example, an all oral routine, that it's very hard for them to leave work and go into a clinic to receive something that's sub-Q or IV. So these are very important options. And, you know, your physician wants to hear from you. So it's very important to be able to have good communication and to be part of the treatment decision. Obviously, very important. It's important to, as I said, create that dialogue, express your goals, your values, your preferences, and so that you can arrive at a treatment decision together. So the doctors do want to hear from you and hear your, you know, your opinion on their treatments. So, you know, it's preparation for appointment in the COVID era, but it's not just in the COVID era. It's always important to be prepared. for your visit with your physician. It just makes, your time to be more valuable when you're sitting in front of your doctor. So you need to write down your questions and concerns obviously about COVID. Obviously infection precautions are important. Obviously too is very importantly is to bring your current medications or your supplements. So when we have to go through the patient's medication list, when we ask them what are they on for a current medication, they'll be like, oh, well, I'm not sure if it's once a day or twice a day. I'm not sure of the name or, how many milligrams. And, we need to keep your records up to date. So it's very important to bring your current medications and any of your supplements that you're taking. You need to talk to the doctor about any medical or life changes since your last visit. You need to tell them if you were diagnosed locally, with pneumonia, that you saw your primary care doctor, etc. And really talk about some current symptoms and how they've changed. We need to know. If we don't know, we can't really, make any changes to make, your lifestyle better. At your appointment, obviously, please wear your mask. Ask your most important questions first. And very importantly, you need to understand your treatment plan and next steps. So if you're, when we get into the doctor's office, if there's so many things going on, we always forget what to ask. That's why I say it's important to write it down. But it's also important to, if you don't understand something, the doctor does not mind for you to say, could you please just repeat that? Or can you just explain it in a different way? And they'd be more than happy to do that. Have a list of who to contact and when, and that's something that usually the front desk can take care of, and include caregivers and always, if you can, especially during COVID times when we weren't allowing, another patient or somebody, a support person with a patient. But now we are allowing one person in with a patient. Another set of ears is always very valuable. And when you're back home, you're going to take precautions to stay healthy. Again, continue to communicate with your healthcare team, pharmacists, etc. Take your medications as directed. Don't be skipping anything. You need to let the doctors know, and you're going to need to follow up with your healthcare team if you have any questions or concerns. So now in this day and age where we see telemedicine visits happening more often, obviously due to the COVID pandemic. And, it's really interesting. I think that they have accomplished quite a bit. You really have the doctors really full attention. So they're looking at you, one-on-one without, all the extra, curricular activities that go along when you're in a clinic and all the noise that's going on and people in and out of a room. So you do have the doctor's full attention. So I do think that these telemedicine visits are valuable. And oftentimes, too, it can help patients who don't have, a support or have a ride into clinic, or patients who are pretty stable that, don't necessarily have to come into the clinic all the time monthly. So for those patients, this telemedicine, certainly can work. So, obviously you need to know how to do the computer and all that. Plan your labs. You can get them in advance and have them sent to your doctor's office. If you need a script, you can tell them when you're on the phone, and this is something they can send, through their, electronic medical system. Very importantly. So it's just very important, again, a well-lit location so they can see you, so, have strong Wi-Fi. That's important too. And, if you need to show a body part, or so if you think you have a rash and you want to show the doctor something, so have accessible clothing that if you need to show that you have a rash, on your chest, for example, that it's easily to get to it. And also, a lot of patients that have at home have those blood pressure monitors, and, the doctor would like to know what your blood pressure is and your heart rate. Oftentimes, it's if you have those oximeters to see what your O2 saturation is, that's also very helpful that you can tell the doctor. And at the end of the visit, you can check for your future appointments, whether it's going to be if the doctor wants to see you next time, or if it would be virtual again. But always importantly, please remember to if you need a medication refill, it's really important to tell the doctor at that visit. It's just easier for them to facilitate that. Infection and prevention and treatment. Well, I will just say that I think we've learned a lot through the COVID pandemic and how important it is to be, very wary of infection that can happen to patients, and to really learn to make patients are washing their hands and they're wearing masks. So it's very important. So report fevers of more than 100.4 degrees, or if you have shaking chills even without a fever, or if you're feeling dizzy or shortness of breath or low blood pressure, you need to obviously let your healthcare provider know. So anyway, patients with multiple myeloma, we have a compromised immune system, and so it's patients with myeloma are more susceptible to infections just based on virtue of their disease. And now we have the COVID variant out there, so we have to be very careful. So again, good personal hygiene with your skin, oral, your environmental controls, wash your hands, avoid crowds and sick people. It's interesting. I have patients say to me that, they haven't had a upper respiratory infection or a cold or pneumonia because, they've been wearing masks and good hand washing and, really staying 6 feet from other people. So we see that we saw less flu this year. I'm sure everybody can attest to that. So I think all of these infection preventions and treatments are really helping patients just to be healthier. We can facilitate and give patients growth factor. So we have the growth factor Neupogen that helps to build up a patient's white count so they can fight an infection. Patients with myeloma, we do give them their immunizations. We don't give them live vaccines, but they can get all their immunizations, making sure they get their flu vaccines. Medications, patients with multiple myeloma are susceptible to infections, and I know in our practice we do have a low threshold for putting patients on antibiotics, but antibacterial medicines are antivirals, so we want to prevent reactivations of shingles. So again, very importantly is infection prevention is, good hand washing, wear a mask, when you're in crowds of people. But the best way to prevent illness is to obviously avoid being exposed. The virus spreads from person to person through respiratory droplets. These droplets are from coughs, sneezes, talking of an infected person. So more droplets with a louder talker. So we got to be careful of those loud talkers, yelling or singing. You're exposed if you're in close contact within 6 feet. That can obviously increase the risk of spread, so of any type of a viral spread from patient to person to person. And droplets can land in the mouths or nose of people who are nearby or possibly being inhaled into the lungs. So COVID-19 may be spread by people who are not even showing symptoms. So, of course, we know we're already worried about the unvaccinated people out there. So just if you're just wearing masks, and if you're washing your hands, you're standing away from people, these are treatments that can at least decrease your chance of getting the COVID-19 or any other type of infection. So multiple myeloma and treatments both contribute to how you're feeling. Obviously, with multiple myeloma, that's a disease of the B cells or the plasma cells, and our plasma cells protect us against disease and infection, but they're not working so well when you have multiple myeloma, so they cannot protect you. So patients with multiple myeloma are susceptible to lots of different issues. Infection certainly. Also, the breakdown of bones can cause what called hypocalcemia, an elevation in their calcium. Patients can have 40% of patients diagnosed with myeloma have some type of renal dysfunction. Those light chains are very small and they're being filtered through the kidneys, causing some kidney damage. Patients can have anemia if they have low hemoglobin. They can have bone pain from bone disease. Bone pain can lead to patients with fatigue, or anemia can lead to fatigue. We talked about infections, and patients can have other symptoms. So the treatment for myeloma, it does kill the cells, but it can cause, obviously some side effects, and the myelosuppression. So what does that mean? It can cause patients to have a low white count, low red cells, or low platelets. But we see patients regularly so that we can monitor you very, very closely. And if your white count is low, we can give you growth factor, the Neupogen. If your red cells are low, we can give you red cells to help with any type of fatigue you may be having. Or if you need a platelet transfusion, if you had bleeding or bruising, we could do that. Some symptoms, the proteasome inhibitors such as Velcade can cause some peripheral neuropathies. And so, again, we see patients frequently so that we can triage and talk to them about any symptoms they're having. And through appropriate dose modification or dosing delays, we can try to mitigate some of the peripheral neuropathies that can happen. Other side effects can be some diarrhea, some GI side effects from the therapies, and again, through dose reduction if need be, or just talking about supplements that patients can take to prevent some of the diarrhea. Patients can have some fatigue. Some therapies that we give in combination can cause deep vein thrombosis, so clotting. So we put patients that we know side effects can happen for a deep vein thrombosis. We put them on anticoagulation. Some of the drugs can reactivate some viral infections such as shingles. So we're on antivirals therapies like acyclovir or valcyclovir in patients and other symptoms. So we want to know how the patient's feeling and some of the side effects that can happen when patients are on therapy. So what happens if the symptoms are not managed? Again, as the doctors were saying, that we need to know what your side effects are. We need to know how you're feeling because we can make changes. And, we tailor a therapy for multiple myeloma to the patient. Not every patient can take the same dosing. So it's very important for us to be able to manage these symptoms, because if we're not managing the symptoms, it can really, lead to some, anxiety or depression or social isolation. We don't want patients to say, well, this is what the doctor told me I have to take, and I guess I have to, put up with these side effects. And that's not the case. Again, we tailor the drug to the patient through appropriate dose modification or changing a patient's schedule or giving them a dose delay for recovery of their marrow can help patients, effectively manage some of these symptoms, because it does lead to, social isolation, reduced quality of life. And we want patients to feel good and have a good quality of life while they're on the myeloma therapies. So very importantly is to discuss with their team, keep a diary of your symptoms. You need to talk to the doctor about it. We want to know how you're feeling. If we don't know, then we really cannot help you to feel better while you're on therapy, and for us to make the appropriate recommendations. Express your priorities. Fatigue is very common concern. By making the right decision is a higher priority for most. And, nobody wants to be feeling not well and tired all the time. So it's very important to communicate openly with your team. We all want to know how you're feeling because we want to make you have your best life and a good quality of life. So with myeloma therapies, all patients, unfortunately, nobody likes the steroids, the dexamethasone. Obviously, steroids are a very important part of your therapy for your myeloma cells. They kill the myeloma cells. But patients, I think out of all the drugs that we give our patients for myeloma, the first one generally we will dose reduce are the steroids. They are extremely difficult for patients to handle. They cause irritability, mood swings, depression, difficulty sleeping, which can lead to fatigue, increased risk of infections and heart disease, muscle weakness, and blurred vision, cataracts, and weight gain, etc. We can go on and on with how the side effects of steroids can be difficult. But we can manage these side effects through appropriate dose modification. We are doing now, through many studies, once weekly dexamethasone dosing, different from the old days when we would, there'd be 4 days of dosing of the steroids. So consistent scheduling, AM versus PM patients I told patients sometimes if you take the steroid at bedtime, that you can sleep off those side effects, during the night. In some patients will say to me, oh, that wouldn't work because I'm up all day. But you know what? Sometimes you have to be consistent in trying it. But a lot of patients feel like taking their steroid at bedtime does help them. But it's whatever the patient feels is best for them. Obviously, take your steroids with food. It can cause some stomach discomfort, so we do want patients to take stomach protectants, medications also that can lower your immune system. So medications to prevent the shingles or thrush in your mouth. So this is why good oral care is important when you're taking steroids too. So these are just some of the ways to manage some of the steroids side effects that we see, because they're generally in combination with all of the therapies we give for patients with multiple myeloma. So, fatigue, depression, and anxieties we see with patients with therapy, receiving the diagnosis of multiple myeloma and then being on therapy for a long time. But, we have come a long, long way in the treatment for myeloma, obviously with great advances in scientific and medical technology. We understand the disease of multiple myeloma better because we know patients are living a much longer time. But therapy over a long period of time, can affect a patient's quality of life. When they're feeling they're anemic, they're in pain, or they have reduced activity. So really important for managing is, exercise. It's really important to go out just for, it doesn't have to be a long walk, and just get up and not sit around the house. And, it's good for your mental health to get up and walk or do some yoga. Obviously, proper rest is extremely important. And, some of the therapies can, like especially the steroids, can keep you up at night. Support, social networks, support groups. You can ask for professional counseling. Social workers or, psychologists or psychiatrists are available for all of our patients. Some patients feel they benefit from meditation or spiritual support or mindfulness. Everybody's different. Everybody can benefit from, any type of, an outside source for helping them to cope with, having the disease of multiple myeloma and some of the side effects. So there's massage, aromatherapy, supplements, transfusion if needed for red cell transfusion. If your hemoglobin is low and you're feeling short of breath or fatigued, a red cell transfusion can do a lot for a patient to make them feel better. So effective management is extremely important. You're not alone. At least 70% of patients experience fatigue, but only 20% tell their provider. So we want to know, so please let your provider know about symptoms that are not well controlled. Obviously thoughts if you were going to ever be harming yourself, because we're here for you, and we want to know, what you're thinking, how you're feeling on therapy, and then we can make the appropriate adjustments. Pain prevention and management. Multiple myeloma patients, due to the bone disease of myeloma, patients can have lots of, serious bone pain that obviously impacts and compromises their quality of life. So we know the pain can be due to bone disease, neuropathy, medical procedures. So prevent pain, obviously, when possible, we give patients those bone strengtheners, the bisphosphonates, to help decrease the risk of future fractures, which is very important. We want patients on antivirals to prevent shingles, because shingles can cause, excruciating nerve pain for patients. So we have to keep all that in mind. Intervention depends on the patient's source of pain. And if your pain you feel is not well controlled, you can ask to see another subspecialist, and you can see, a pain control specialist, within your hospital that just works on patients' pain issues, and that helps quite a bit. Complementary or alternative medications, supplements, or acupuncture, etc. So just tell your healthcare provider about any new bone pain or chronic pain that is not adequately controlled. So obviously, as we know, knowledge is power, and you're not alone. And the International Myeloma Foundation has many, many resources to help patients. It has lots of patient resources and information about any of the therapies that you're being prescribed by your myeloma specialist. It also has information on side effects that patients can experience due to these therapies or just from the disease of myeloma alone. And this is something that you can read, and we'll talk about, and management that can help you to, better withstand any type of side effects that you may be, enhancing or enhancing and getting worse. So knowledge is power. So through the myeloma.org website, you're able to download or request any of this information about the drug therapies, supportive therapies, or the latest news that's going on at ASH or any of the major, hematological association meetings to find out what the latest is in multiple myeloma. So using that website is a plethora of information that's available for patients and their caregivers. So with that, I'll just say thank you very much, and I guess we'll move on to some questions.
I love that word, plethora.
All right.
We have a plethora of information at myeloma.org, and I think that it would behoove you if you've just gone on our website here or on our program here today, is just to go to the website and spend a few minutes. You'll get an email, the attendees, you'll get an email with all the slides and the talks, and you'll be able to go back and listen to this. Kathleen, great talk. Thank you as always. I love working with the Nurse Leadership Board. All right, we have a lot of questions from a couple people, about 5. I'd like to go over them, starting with Carolyn's. Mika, will you rise that up a bit for me? And it says, Carolyn, yes, I have DARA on Tuesday and Thursday, got my second vaccine. I've been treated 2 times and have no antibodies. What should I do now? Anyone want to take that question? Please do. Okay.
Depends on, your doctor, your state, and what's going on. I mean, again, as you heard, the antibody may not be the whole story in terms of whether you're immune or not. I personally, and I talked to our state health commissioners, and I got permission in Indiana that I could, based on clinical judgment, recommend 3rd or even 4th vaccine. And I've been able to do it. I think it depends on your, state, depends on your healthcare coverage and things like that. So I don't want to say that this is easy, and can be done, everywhere. But I think this is a clinical judgment. I mean, I think your physician and you should sit down in the room and talk about it. Talk about risk and benefit. What is it, that bother you not having the antibodies? What is it about getting revaccinated? What are the risks and the benefit? And discuss it. I think, this is an important medical decision. Nobody can tell you what to do except you and your doctor.
One question just came up. Can I use different steroid instead of Dex to reduce side effects of Dex? For example, Dr. Paner, I can't pronounce that word, methylprednisolone.
I'm a big fan of that. I actually use that more than I use dexamethasone. I think it's shorter acting, and so it gets out of the body quickly. So I'm a big fan of it.
Dr. Paner?
Sometimes prednisone can also be used in regimens. But there are also many ways to work with a dose of dexamethasone. I'm actually probably get rid of dexamethasone pretty quickly. There are plenty of studies now showing that it's really good in the beginning of treatments, and then it does more harm than good over the time. So I think this is the drug that's hardest to tolerate and needs a lot of attention and fine-tuning with a dose of it. Mm-hmm.
Let's go to George. Okay, great. George has a question. Is it possible to collect stem cells on a 10-year-old patient, I guess, to make sure CAR T cells or BMT and have these treatments right now? So in essence, can they collect them after treatment?
Well, I mean, you can use frozen T cells. The question is that who's going to pay for it and how you're going to, store it and all that stuff. I think, so the technicality may get in the way of doing that.
Is it a question on a 10-year-old person or a patient who has had
patient? I'm going to say 10-year patient.
Okay, not a child. For sure not on a child. The odds that this will happen in someone's lifetime are extremely small and doesn't run in a family. So, yeah, what I will point out that it's not the same cells that get collected for transplant and for CAR T cells. T cells are different from stem cells. It's the T cells that get collected for CAR T cells, and that can be done at any time. While for transplant, the stem cells we usually tend to collect in the beginning, and then, down later in treatment, that would be very selective cases. It really depends on a lot of factors. It would not be standard of care. Mm-hmm.
All right, let's take George's question number 11. Go ahead and read that out.
Mm-hmm.
Dr. Paner or Dr. Rafat?
I can't
Rafat.
see it.
Let me see if I can get to it.
Can you see it?
No.
Yeah, I see now. So is extramedullary plasmacytoma better progressive than multiple myeloma with bone? I'm trying there's many ways to interpret the question. So,
I guess the question, plasmacytoma at diagnosis versus probably relapse with plasmacytoma, if you can explain that.
Yes, in general, extramedullary plasmacytomas is a sign of aggressive disease. Unless patients present with solitary extramedullary plasmacytoma, those patients actually have smaller chance of progressing to multiple myeloma than those presenting with solitary bone plasmacytoma. But once disease is multiple myeloma, no longer solitary, then actually extramedullary plasmacytomas in a way are worse than bone plasmacytomas, but you have to take many, many other things into account as well. So not sure if I answered it.
Best shot there. Jim had another question about COVID shots. Dr. Rafat, will you take that question? Any of the COVID-19 shots effective if you take Pomalyst?
Yeah, so being on immunomodulatory drugs like Pomalyst, Revlimid, thalidomide is actually may enhance your immune response. Seeing no problem, patients on Pomalyst or Revlimid developing an antibody response to vaccine. Actually, they do very well. They respond.
Okay. George has got a lot of questions today.
I want to meet George.
I want to meet George, too. He's asking some good questions. Would either one of you want to take his recent question? How do you make a right decision?
You go see Dr. Paner and sit down with her and talk to her about it.
And that's so far what's available, not genomic analysis. So I think it's a very, good research question that George is asking. How do you make a right decision of multiple myeloma patients on many treatments? Do you have cross-matching on genomic analysis with your medicines and treatments? So I really wish we had something like antibioticogram, the way we do for bacteria, where we grow them in a petri dish and we can tell which antibiotic is going to work and which not. We don't have that yet in oncology. There is research happening around it, but it's not available in clinical practice.
I'm going to ask you a question then. I'm going to ask you a question because there was actually somebody mentioned that in the chat. What's your approach for somebody with relapsed myeloma that has a translocation 11-14?
Yeah, so I was going to say a few exceptions would be translocation 11-14. Those patients can be more susceptible to venetoclax, but it is not FDA approved, and I'm not sure it will because of the issues that came up in the phase 3 trial. It was very promising in phase 1 and phase 2, but then in phase 3, while it was effective therapy, it had certain side effects that it almost made it look worse than the standard of care therapy. So that's why it's so important to do phase 3 trials to get an ultimate answer. So if I were to use it, it would be very much on selective cases for patients with translocation 11-14 who are running out of options. And
I hate to use anecdotal experiences, but I have a patient who have failed every approved regimen, including CAR T cells on a clinical trial. And now he is on carfilzomib and venetoclax, and he's in remission.
Oh, that's great.
So, I mean, I think we need to explore that combination.
Yeah, there was no question that it works. It was the side effects, that the increased risk of infections, I believe, that was a problem.
And I think that was probably because it was an international study, and I think the supportive care overseas is not similar to what we do here. I think we have better access to treatment quickly and better antibiotics access. So it could be different, you know, if we just do the study in the U.S.
Yeah, absolutely.
Well, with that being said, are there any, Dr. Rafat, do you have any additional comments to make?
No, I just think it was a good presentation. I think Kathy did a fabulous job. I mean,
I agree.
Doing a lot of things. So she can tell us more about her role there.
Dr. Paner, you have anything else you'd like to add?
Well, I would like to encourage patients to get vaccinated for COVID and, you know, stay hopeful and positive. There's a lot of new treatments coming up in myeloma. Keep an eye open on clinical trials, because that's the only way we can make things better long term.
Oh, and Kathleen?
Well, I was going to say the same thing as Dr. Paner, is that, you know, how important clinical trials are and your participation in clinical trials. And it's because of you, the patients, that we have so many new therapies, you know, for the treatment of multiple myeloma. And as Dr. Abonour said, I also believe that patients are living longer because of good supportive care. We understand the disease better. We understand how to manage all of the side effects of all the therapies that our patients are taking. And with good supportive care, with the great therapies that we have today, patients participating in clinical trials, this is why we have all the therapies that we have had. I mean, it's really, I think, unprecedented since the year of really 2000 to where we are, you know, 21 years later with the therapies that we have today. And my role as a research nurse at Dana-Farber, as I said earlier, for me to see all of these therapies become approved by the FDA is inspiring, and I've been honored to be a part of it.
You guys are inspiring. I really, really appreciate taking time out of your Saturday. I know that we're all busy, and taking some time with some great patients. They're all good to me. And I just can't thank you all enough. Really appreciate it.
Thanks for having us.
Oh, you're
Thank you.
welcome.
My pleasure.
As follow-up to today's workshop, we'll have these speaker slides and video replay available. So that's enough. You'll see that in your emails for all of you that registered. Feedback. Gosh, folks, this is the most important thing I can get from y'all. I need to know what you thought of the content. I need to know what you thought about the timing. I need to know what you thought about the slides, the mechanism of delivering to them, etc. So please just take a minute. It's not a long survey. Next slide. Let's do this right again. Thank you to our supporters and sponsors: Amgen, Bristol Myers Squibb, GSK, Janssen, Karyopharm, Oncopeptides, Takeda Oncology. And that's it for
Very
today.
good.
Thank you. Bye, everyone.
Thank you. Bye. Thank you.
Thank you.
Is that it?